Am I audible clearly?
Yes, yes.
Okay. Good evening, everyone. Uh, Happy New Year to everyone. And let's start this rhinology module. The first talk will be anatomy of nose, paranasal sinuses, and anterior skull base, the basics of anterior skull base. I am Dr. Udaya Chanukya, working as an ENT consultant in Rajahmundry. Before jumping into the lecture, I would like to thank Dr. Janakram sir, my teachers, Dr. Murthy sir, Janakram sir, Himesh sir, and Veer Kumar sir, who have taught me the basics of ENT, and without whose support, I would not be what I am today. And I would like to thank Sahasra ENT Foundation also to have initiated such a wonderful program to interact with young ENT surgeons all over the India and maybe, if God permits, all over the world, and to share my small amount of knowledge with everyone. Okay, starting the lecture. The skull base anatomy, or the nose and paranasal sinus anatomy, is not as scary as it looks like the skull. It is pretty easy to understand, but what we have to do is we have to just go into the basics, learn the basics right, and then apply it in our surgical practice. This is the anterior view of the skull, and this is the posterior and lateral view of the skull. Coming to the parts of the skull, there are two parts of the skull. One is viscerocranium and the other one is a neurocranium. The viscerocranium is the facial, face proper. That means the bones, etc. The anterior part of the face. The neurocranium is the part which covers the brain. So the neurocranium is formed by frontal bone, sphenoid bone, two parietal bones, and two temporal bones, whereas the viscerocranium is formed by another 14 bones. So there are a total of 22 bones according to one count and 29 bones according to another count. Why is this variation? If you count the 8 cranial bones and 14 facial bones only, it will be a 22 bones. Whereas if you count the 3 plus 3 middle bones on either side, along with the hyoid bone, it will be a 29 count. Okay. Now, one can easily think, how can 22 bones or 29 bones just be in this compact place, compact skull? How can they be articulated? I was also in search of such a thing when I was in PG, and fortunately I found this animation which clears our doubts. These are the various bones which are seen from the lateral view, and these are the bones which can be seen in the anterior view. Every bone has been designated with a different color. So this is the 360-degree rotation. Without wasting much time, we'll jump to the place where the actual disarticulation will be seen and the articulation will be seen, so that we can see how compactly and how beautifully God has arranged this skull. So see how they have been disarticulated. This central bone, the yellow bone, is the most complex bone of the whole skull, and is the sphenoid bone. And this side bone, this is the temporal bone, and this is the most versatile bone of the body. So it has the most complex bone and the most versatile bone in the same place, in the same part of the body, that is the skull. So that is how they are disarticulated and again articulated. See how beautifully and compactly they have been articulated and giving us protection and the appearance at the same time. Coming to this nose, what nose is the landmark of face. If the face is the index of mind, the nose is the index of the face. Nose is the most prominent, and it is not exaggeration. It is not an exaggeration to say that the nose gives the shape of your face. The beauty of your face lies in your nose. That is why many people get rhinoplasty done in order to improve the appearance of their face. Coming to the overview of this talk, we'll discuss about the external part of the nose, the internal part of the nose, the individual bones and sinuses, along with their anatomical variations, basics, very basics of the anterior skull base, and a small video demonstration of a cadaver dissection done by Dr. T.N. Janakram. At the end, we will not deviate from our overview, because in a very limited time, we have to cover the whole anatomy in an understandable manner. The exclusions will be embryology and anatomical anomalies of the nose. Coming to the external part, this is how an external appearance of the nose looks. There are two nasal bones at the root of the nose, and a upper lateral cartilage, a paired part of the upper cartilages, and the lower lateral cartilages below it. Coming to the lateral view, we can see it more clearly. This is the nasal bone, and these are the upper lateral cartilages and these are the lower lateral cartilages. These upper lateral cartilages articulate with the septal cartilage in the midline and articulate with the fibrofatty tissue laterally. These lower lateral cartilages are again divided into three parts: the medial part, the intermediate part, and the lateral part. The medial part is combined with the medial part of the opposite side. The lateral part or the intermediate part forms the prominent part of the ala, and the lateral part is what which gives the contour of the nose. You can see this lateral lower lateral cartilages are incomplete, and this is completed by the fibrofatty tissue, and you can also see minor cartilaginous of the ala also. Going to the internal part, the first thing is septum. Septum is formed by two types of tissues: a cartilaginous part, which is the hyaline cartilage, and a bony part. This anterior part is formed by the quadrilateral shaped septal cartilage, which articulates with the perpendicular plate of ethmoid above and vomerine bone below. The septum is formed by perpendicular plate, quadrilateral cartilage, and vomerine bone, which is attached to the maxilla below, the crest of maxilla below. The whole septum is formed like this, and it sits on the crest of maxilla. That is why when we do an endoscopic septoplasty, if we want to release it from below, we goose at the maxillary crest. What is septal swell body? Septal swell body is a finding which is most commonly seen in a CT scan. This will be discussed by Dr. Venkatram Reddy garu tomorrow. But in order to have a brief overview, it is a widened region of the anterior nasal septum, and it is located at the anterior part of the middle turbinate at the internal nasal valve. What is internal nasal valve? We'll have a discussion later in the presentation. And histologically, it has increased amount of venous sinusoids and fewer granular elements. The other part of the septal mucosa has more or less equal and more part of the granular elements, but this part has an increased venous sinusoids and lesser granular elements. What is the function? Because it has the capacity to alter the nasal flow. Whenever the venous sinusoids are engorged, it has the capacity to alter the nasal flow in a similar manner to the inferior turbinate. Coming to the lateral wall. Lateral wall is divided into three subparts. 1. Vestibule, 2. Atrium, 3. Conchae and meatus. Again, the lateral wall of the nose has cartilaginous part and a bony part. The lateral cartilaginous part is formed by the upper lateral and lower lateral cartilage along with the minor cartilages, whereas the bony part is formed by various bones. Numerically, to enumerate, it is 7 bones, 7 separate bones. Each of them are designated with a different color, starting in the nasal bone, frontal process of maxilla, lacrimal bone, ethmoid labyrinth with the superior and the middle turbinate. This is the independent inferior turbinate. This one is the perpendicular plate of the palatine bone, and this is the medial pterygoid plate. See, whenever, if you can remember, just remember the whole names and the articulation, because each of these posterior bones has a very important significance when we go later into the presentation, when we discuss about the Pterygopalatine fossa and infratemporal fossa. So I'll just repeat it, starting with the nasal bone, frontal process of maxilla, lacrimal bone, ethmoid labyrinth with both superior and middle concha, inferior concha. Concha is nothing but a turbinate. 6. This is perpendicular plate of the palatine bone, and this is the medial pterygoid plate. Coming to the nasal valves. Why are nasal valves important? There are 2 nasal valves located in the nose, which are external nasal valve and internal nasal valve. This is the midline sagittal section showing the external and internal nasal valve. And what is the difference? Difference is the location. External is located much more anterior to the internal nasal valve, as the name suggests. The boundaries of the external and internal nasal valve shown endoscopically are both have a same medial border, that is septum, but the lateral border and the inferior border is what changes. The lateral part of the external nasal valve is formed by alar rim, comprised of the lower lateral cartilage crust. Lower lateral cartilage is the lowermost cartilage on the lateral wall, whereas the lateral part of the internal nasal valve is formed by the caudal edge of the upper lateral cartilage. See, the upper lateral cartilage and the lower lateral cartilage. Upper lateral cartilage is the articulates with the lower lateral cartilage. So the junction, when we see like this, The upper lateral cartilage's lower border forms the internal nasal valve, whereas the lower lateral cartilage's lower border forms the external nasal valve. The inferior part of this external nasal valve is formed by nasal seal, whereas the internal nasal valve is formed by the head of the inferior turbinate. Head is nothing but the anterior part of the inferior turbinate. What is the significance of internal nasal valve? Internal nasal valve is the point where the airflow is regulated most. If not going into physics, let's leave it. So it is the most important part which regulates the airflow into the nasal cavity, or to be precise, nasal resistance. Nasal resistance is what is regulated by the internal nasal valve. Okay, next. Coming to the blood supply of the septum and lateral valve. More or less, the septum and the nasal lateral valves are supplied by anterior and posterior ethmoidal arteries and sphenopalatine arteries, various branches, and a minor part is contributed by the greater palatine arteries. Coming to the septum, the anterior and posterior ethmoidal arteries supply the superior part, and the anterior supplies extra the anterior part, whereas the sphenopalatine septal branch of the sphenopalatine artery contributes to the majority part of the nasal septum, and the septal branch of the greater palatine artery and superior labial artery contribute to the smaller antero-inferior part. All of these branches form a confluence at the antero-inferior part of the septum, which is called as the Kesselbach's plexus. Harsha, is the voice having any disturbance?
No, you can go ahead.
Because I am seeing some comments which are saying the voice is breaking a lot, so I'm just worried about that.
No, sir, it is fine. Maybe they're
Fine, right? I'll continue. Okay. So just repeating the Kesselbach's plexus. Kesselbach plexus is the confluence of the anterior ethmoidal artery, sphenopalatine artery, superior labial artery, and greater palatine artery at the anterior end of the septum. And coming to the blood supply of the lateral wall. Lateral wall, just remember 3 arteries or 4 arteries: anterior ethmoidal artery and posterior ethmoidal artery, supplying the superior and antero-inferior part. The sphenopalatine artery again forms the major chunk of the blood supply. Remember, sphenopalatine artery gives one middle turbinate branch and one inferior turbinate branch. That suffices everything. Sphenopalatine branch supplies to the middle turbinate by a middle turbinate branch and the inferior turbinate branch, which can be seen diagrammatically like this, and this forms the major blood supply. And greater palatine artery is also given, supplies the smaller part of the lateral wall. Coming to the anterior and posterior ethmoidal arteries, these are significant because these orbitocranial canals, and these both are given by the ophthalmic artery, again a branch of internal carotid artery. This ophthalmic artery and the optic nerve travel together in the optic canal and enter through the optic foramen. The posterior ethmoidal artery and the anterior ethmoidal artery are given along when they at the skull base. The significance being these two arteries are vulnerable to damage while doing an endoscopic sinus surgery. Just vulnerable, and how to identify them, what are the landmarks, how these two arteries play a role in classifying the areas of skull base, we'll see in the later part of the presentation. Coming to the external nasal innervation. Why is an external nasal innervation important? Because this is very important in order to have a sensory nerve block. In order to have a partial block of the partial block, we can just inject in the areas proper. This is the area of supratrochlear nerve. This is the area of infratrochlear nerve. This is the area of anterior ethmoidal nerve, and this is, one can easily say, this is the area of infraorbital nerve innervation. Coming to the nerve supply of the septum and the lateral wall. Again, remember, one of the most important one of the important functions of the nose, apart from filtration, is olfaction. So it has to be supplied by olfactory nerve at some point. So olfactory bulb gives olfactory nerves through the cribriform plate. Cribriform plate, the olfactory nerves supply both superior part of the nasal septum and the superior turbinate, area near the superior turbinate on either of the walls, the medial wall and the nasal lateral wall. So that forms the olfactory nerves or the olfactory bulb. Apart from this, there are posterior superior lateral nerve, lateral nasal nerve, posterior inferior lateral nasal nerve, nasal branch of the anterior superior alveolar nerve. All these branches which come from the sphenopalatine foramen, and these are the nasopalatine nerves which form the septum also. Okay, The septum is also supplied, septum and the lateral wall are also supplied by the anterior ethmoidal nerves too. Coming to the venous drainage, the superior part directly drains to the cavernous sinus. The posterior and the inferior part mostly drain to the pterygoid plexus in the infratemporal fossa. The anterior inferior part drain to the facial veins. Coming to the middle turbinate, why are we discussing middle turbinate separately before going to paranasal sinus? Because middle turbinate is divided into three segments. These three segments are attached at different places and located in three different planes. The first part is located in the sagittal plane. It is attached to the skull base at the lateral lamella. The coronal segment creates the basal lamella. What is basal lamella? We'll discuss later. The basal lamella is the partition between anterior and posterior ethmoidal sinuses. If the middle turbinate is starting like this is left nasal cavity. Okay, middle turbinate in coronal plane, middle turbinate in sagittal plane, starting part, which is attached to the lateral lamella. Middle turbinate in the coronal plane. Coronal plane is dividing the anterior and posterior ethmoidal air sinuses, and middle turbinate in the axial plane. Middle turbinate in the axial plane forming the posterior most part, and it is attached to the lateral wall of the nose, and where the entry of the terminal vein to the sphenopalatine artery is occurring. Coming to the paranasal sinuses.
Sir, can you repeat that? There's a middle turbinate attachments.
Middle turbinate attachment. Okay. Just have a paper. Okay. So middle turbinate is somewhat located like this. Okay. This is the coronal part. The starting part is coronal, and once we come posteriorly or slightly posteriorly, it forms the first part is sagittal. Sorry, sagittal part. Once we come posteriorly, it becomes a coronal, which divides two parts of the ethmoid cells, like anterior and posterior, and the final part is attached to the axial. It is in the axial plane attached to the lateral. Harsha, we have a small dissection video ending in the ending, so that I can explain it at that point of time, which will be much more easier.
Okay, sir.
Okay. Just remember me if I forget. Mostly it will be shown because it is the only a 15-minute video which I am showing. And if ever they have any doubt, I can explain it at that point of time. Okay. Will I proceed? Shall I proceed?
Yes, sir.
Yeah. Coming to the paranasal sinuses. First sinus is maxillary sinus. Maxillary sinus is also known as antrum of Highmore. It is located inside the body of the maxilla and is communicating with the environment by the middle meatus and the nasal vestibule. It is largest of the all sinuses. This is an important picture. How is the maxillary sinus located? The maxillary sinus is a pyramidal shaped sinus. Pyramidal shaped sinus with its lateral wall or the base of the pyramid towards the lateral wall of the nose. See, this is the lateral wall of the nose, and this is where maxillary sinus is located. So this lateral wall forms the base of the maxillary sinus, which is a pyramidal shaped structure. The base of the maxillary sinus is formed by the lateral wall of the nasal cavity. Obviously, it will have the maxillary ostium in the base of the pyramid. The anterior wall is formed by the facial surface of the maxilla. This is the facial surface of the maxilla, which forms the anterior wall. And posterior wall is formed by the posterior wall of the maxillary sinus forms the anterior wall to the all the structures behind it. The fossa, Pterygopalatine fossa, infratemporal fossa, everything goes behind the maxillary sinus. And this posterior wall forms the anterior surface of the all the fossas, and it forms the infratemporal fossa surface of the maxilla. The roof forms the orbital floor. Roof of the maxillary sinus is forming the orbital floor, whereas the floor forms the alveolar process of the maxilla. Floor is formed by alveolar process of the maxilla. There are some one or two teeth also protruding into the maxillary sinus according to the dentition. So the apex is directed towards the zygomatic arch of the same side. There are one floor or the base which is towards the lateral nasal wall, roof towards the orbital floor, posterior wall towards the infratemporal surface of the maxilla, anterior wall to the facial surface of the maxilla, apex towards zygomatic arch. Inferiorly, it is having the alveolar process of the maxilla. One important structure which traverses along the roof of the maxillary sinus is the infraorbital nerve and infraorbital bundle of vessels, which is traversing in the infraorbital groove, and it opens onto the anterior wall of the maxilla, and which gives the innervation like what we have seen in the earlier external innervation picture. Okay, we'll proceed to the next slide. The base of the maxillary sinus, which is this is the base of the maxillary sinus, or the medial surface of the body of maxilla, gives a large opening called the maxillary hiatus, which is compacted in size. The hiatus as such is a bigger size thing, but it is compacted in size by various bones which are articulated above and below it, namely an uncinate process superiorly, descending process of the lacrimal bone anteriorly, ethmoidal process of the inferior turbinate inferiorly, and perpendicular plate of the palatine bone posteriorly. It is hard to imagine with this theory. I will show you the diagram. See, this is the maxillary hiatus, somewhere around here. If you remove all the bones, we can see the maxillary hiatus. But this is compacted by anteriorly lacrimal bone, superiorly this is the uncinate process, inferiorly this is inferior turbinate, and posteriorly this is palatine bone, perpendicular plate of the palatine bone. Imagine a space without all these coverings. It will be a big hiatus, which is the maxillary hiatus, but it is compacted in size by these bones, namely lacrimal anteriorly, uncinate superiorly, inferior turbinate inferiorly, and perpendicular plate of the palatine bone posteriorly. Coming to the arterial supply of the maxillary sinus, it is from maxillary and the infraorbital arteries by the anterior, middle, and posterior superior alveolar arteries. Lymphatic drainage into submandibular lymph nodes. The nerve supply is given by the anterior, middle, and posterior superior alveolar nerves from maxillary and the infraorbital nerve. The next thing is the ethmoid bone and sinuses. We will have a small animation which can clearly, which is better for understanding. Ethmoid bone is an unpaired bone located in between the two orbital cavities. The parts of the ethmoidal bone are the cribriform plate, the crista galli superior to the cribriform plate, a perpendicular plate of the ethmoid below it, and a labyrinth on both the sides. This is the central part of the ethmoid bone with the bilateral labyrinth articulating towards the center. The superior part is crista galli and the inferior part is the perpendicular plate of the ethmoid. This is towards the nasal cavity and this is in the cranial fossa. Coming to the cribriform plate, it is located in the ethmoid notch with orbital plates bilaterally. The cribriform plate separates the nasal cavity and the anterior cranial fossa. The cribriform plate is nothing but a sieve-like structure which transmits the olfactory nerve, which gives a sense of olfaction from the nasal cavity towards the olfactory bulb. Coming to the crista galli. Crista galli is a triangular structure which is located in the cranial fossa above the cribriform plate. This crista galli gives the attachment to the fox cerebri. Coming to the inferior part, that is the perpendicular plate of the ethmoid, it is articulated, it is part of the septum below the cribriform plate and is articulated to the anteroinferiorly quadrilateral cartilage. This is the bilateral bony labyrinth on the either sides, which lodges the ethmoidal air cells, which are separated by smaller bony septae. There are three groups of ethmoidal air cells, or namely two groups, anterior and posterior. The anterior cells are more in number and lesser in size, whereas the posterior cells are larger in size and less in number. Okay. The lateral surface of the labyrinth is forms the medial wall of the orbit, whereas the medial surface has two different concha, that is the superior turbinate and this is the inferior turbinate. These are on the medial surface of the bony labyrinth. Coming to the articulations of the perpendicular plate of the ethmoid, it is articulated anteroinferiorly to the septal cartilage, which is forming the septum. Posterior inferiorly it is articulated to the vomerine bone, anteriorly to the nasal bone and the frontal bone, whereas posteriorly it is articulated to the sphenoid bone. Coming to the articulation of cribriform plate, it is in the ethmoidal notch of the articulated to the orbital plates laterally and the sphenoid bone posteriorly. This is the ethmoid labyrinth. It is articulated to the frontal bone superiorly, sphenoid bone posteriorly, maxilla inferiorly, and lacrimal and the palatine bone also, which cannot be shown in this animation. These are the inferior nasal concha, which are articulated, which is inferior articulation. Coming to the different types of ethmoidal layer cells. There are two most commonly named ethmoidal layer cells, which is the bulla ethmoidalis, and this is the largest and the most consistent anterior ethmoidal layer cell, whereas agarnaceae is the anterior most ethmoidal layer cell. And the pneumatization of what is the clinical significance? Because pneumatization of agarnaceae influences the thickness of the nasofrontal beak. How? We learn in a short while. Supraorbital ethmoidal layer cells. These are clinically important, the supraorbital layer cells and suprabullar ethmoidal layer cells. Coming to suprabullar ethmoidal layer cells. Suprabullar ethmoidal layer cells, as the name suggests, are the ethmoidal layer cells which are the anterior ethmoidal layer cells that extend superiorly over the orbit. Supraorbital ethmoidal cells extend superiorly and laterally over the orbital roof. I think Venkataramaredi garu tomorrow will show these actual images and the CT images of these different types of ethmoidal layer cells. What is the clinical significance of the supraorbital ethmoidal layer cells? One, they can cause obstruction if there are many supraorbital ethmoidal cells high pneumatization. They can obstruct the frontal recess. They can be falsely mistaken for the true frontal sinus, leading to incomplete surgical dissection. And the third most important thing, whenever most of the PGs might have already listened their superior saying, is the anterior ethmoidal artery dehiscent or not? The dehiscence of the anterior ethmoidal artery is because of presence of a supraorbital ethmoidal air cell or supraorbital pneumatization. In this situation, the anterior ethmoidal artery, which is actually located in the skull base, which is flush with the skull base, if there is a pneumatization above, the anterior ethmoidal artery, it will hang in a mesentery. Mesentery is nothing but a mucosal fold. Normally, without any supraorbital pneumatization, it should be coming in the skull base, flush with the skull base. But if there is a pneumatization, what will happen is it will hang with the mesentery. So in the CT scan, it is shown as a different, in a separate vessel below the skull base. That is what a dehiscent anterior ethmoidal artery or a ethmoidal artery hanging in a mesentery means. If we, by mistake, if we are not aware of that, we can actually damage, there can be a damage occurring to the anterior ethmoidal artery also. So these are the clinical significance of the supraorbital ethmoidal layer cells. Another type of cell is suprabullar cells. The suprabullar cells are the frontal bulla cells, are the pneumatized extensions above the ethmoidal bulla up to the skull base on the posterior table of the frontal sinus. On the posterior table, remember, frontal sinus drains into the nasal cavity via the frontal recess. Frontal sinus, as of it, is not any clinically significant. The most important significance is of the frontal recess, because this is what we should worry about. And this frontal recess has a the frontal sinus has a posterior table and the anterior table. When the bulla, which is posterior to the frontal sinus, pneumatizes towards the posterior table, that forms the suprabullar cells. We have a cadaver dissection, which I can show you shortly. Cadaver dissection picture, which I can show you shortly. These cells can become quite large and mistakenly for the skull base or posterior table of frontal sinus. Okay, 1 minute. We'll just go to that picture and come back. Just give me a moment. Yeah. So this is the frontal sinus, and this is the frontal recess, and this is the bulla ethmoidalis. Whenever the pneumatization goes towards the posterior table of the frontal sinus. This is the suprabular cell, and see how it has narrowed the frontal recess also. This is the suprabular pneumatization. Now we'll just reinforce it. Suprabular are the cells pneumatized extension above the ethmoidal bulla up to the skull base and down to the posterior table of the frontal sinus. This is what we have just seen in the dissection picture. Coming to the sphenoid bone and sinuses. Sphenoid bone is a central and complexly located, centrally located bone in the cranium skull. See, this is the anterior contribution of the sphenoid bone. This is how we can see it laterally. This is the contribution of the sphenoid bone when we have the cut section at the calvarium level. This is how it contributes to the anterior cranial fossa and middle cranial fossa. This is how we can see it from inferior. The green colored part are the sphenoid bone. We'll have a short animation so that we can understand it in a better way. The sphenoid bone is known as os sphenoidale in Latin. This is the sphenoid bone is the most complex bone of the nose. It is also known as the vas bone, given to its shape. This is at the level of the maxilla. If you have a section at the maxilla level, and we can see, if you see inferiorly, the green colored part is the sphenoid bone. This is the infra greater wing of the sphenoid, and these are the pterygoid parts. Cut section at the glabellar level. This is the contributes to the floor of the anterior cranial fossa and middle cranial fossa. And if we do a sagittal section, this is how it contributes to the cranial fossa. There are four main parts of the sphenoid bone, namely the body of the sphenoid, lesser and greater wings, and the pterygoid process. Coming to the body of the sphenoid bone, it is a centrally positioned structure which is contributing anteriorly to the nasal cavity and laterally towards the medial wall of the optic canal, from where the optic nerve and the superior ophthalmic artery enter. Superiorly, it contributes by giving the sella turcica, hypophyseal fossa, and dorsum sellae. And these contain the anterior and the posterior clinoid processes also. Coming to the sphenoid sinus. Sphenoid sinus are located in the body of the sphenoid sinus posterior to the nasal cavity. They are separated by intersphenoidal septum. The lesser wings, oh my god, okay, just a minute. This is the sphenoid bone. This is the body of the sphenoid. This is the lesser wing of the sphenoid. This is the greater wing of the sphenoid. And these are the pterygoid processes, namely a lateral pterygoid and a medial pterygoid. Body, lesser wing, greater wing, pterygoid. The space between this body, lesser wing, and greater wing is the superior orbital fissure. Body, lesser wing, and greater wing is the superior orbital fissure. The lesser wings arise from the superior part, whereas the greater wings arise from the lateral part, and the pterygoid process arises from the inferior part of the body. Okay, with this knowledge, we'll go to that part. Coming to the lesser wings form the optic canal, from where the optic nerve and the ophthalmic artery enter the, and superiorly they form this contribution to the middle cranial fossa and anterior cranial fossa. Greater wings arise from the lateral part, and these forms the posterior surface of the orbit, and they form the infratemporal surface in the lateral surfaces form the infratemporal, whereas the anterior surface form the orbit. The greater wings also have three important foramina by name foramen rotundum, which transmits the maxillary nerve, the foramen ovale, which transmits the mandibular nerve, and the foramen spinosum, which is located in the posterior part of the greater wing, which transmits the middle meningeal vessels. Coming to the superior orbital fissure, this fissure is located, as we already discussed, between the body, lesser wing, and the greater wing, and it transmits quite an important structures, namely superior ophthalmic vein, ophthalmic nerve, abscess nerve, oculomotor nerve, and trochlear nerve. Coming to the pterygoid processes are located attached below to the body of the sphenoid. They lodge two canals by name pterygoid canal, which give rise to which form the channel of major petrocellular and deep petrocellular, and the palatovaginal canal, which lodges the pharyngeal nerve. Coming to the articulations of the sphenoid bone, the sphenoid bone is attached to the frontal bone with the spinofrontal suture, the parietal bone with the spinoparietal suture, the squamous part of the temporal bone with the spinosquamous suture, and the occipital bone with the spino-occipital suture. This is sphenoid sinus, sphenoid bone. Coming to the types of pneumatization of the sphenoid sinus. Sphenoid sinus is pneumatized in four different types, namely a conchal type, a precellular type, a cellular type, and a complete cellular type. This is the cella turcica. So anywhere away from cella is conchal, or the limited pneumatization is conchal. Anterior to the cella is precellular. Nearing to the cella or in the cella is cellular type, and completely till the posterior part is the complete cellular type. Just showing you a CT scan of the various pneumatizations because we can understand it in a better manner. This is the cella. No pneumatization is conchal. Limited precellular. Into the cella or below the cella is cellular, and completely behind the cella is complete cellular pneumatization. Most common is the cellular pneumatization. 90% of the cases, around 85 to 90% are cellular pneumatization. Coming to the interior of the sphenoid sinus. Sphenoid sinus interior is another important thing because we have many landmarks located inside it. So we all know the sphenoid sinus is divided into two. There are two sphenoid sinus separated by intersphenoid septum, and the intersphenoid septum generally often not located in the center. It is either towards the right side or the left side. In this, it is towards the right side, and it is one important thing to remember is this attachment of the intersphenoid septum is onto the vital structures behind these walls. So before breaking it, we have to be very careful because they can actually damage the vital structures behind it. So in this, the intersphenoid septum is towards the right sphenoid sinus. That is why the left sphenoid sinus is big. In such cases, we generally say it is a left dominant sphenoid. If this goes the opposite way, it will be a right dominant sphenoid. So once this intersphenoid septum is taken completely, this is how the interior of the sphenoid sinus looks. This was the earlier attachment of the intersphenoid septum. Now the important structures we have to see in this is, the most important thing is the internal carotid artery. This is the internal carotid artery, left-sided, right-sided internal carotid artery. This is the optic nerve. This is the optic nerve. These two optic nerves enter and they form the optic chiasma somewhere inside here. Carotid. This bulge is cella, which has the pituitary behind it, and this fossa is clivus. Clivus is below this. Now, this carotid beside this clivus is paraclival carotid. Carotid, paraclival, paracellular, cavernous, intradural. Paraclival, cellular, paracellular, cavernous, intradural. So that is how a carotid artery course is seen here. And this optic nerve forms a recess when it is in relation to the carotid. And this recess is the lateral carotico-optic recess. A recess formed with the carotid and the optic on the lateral side is the lateral carotico-optic recess, LOCR, lateral optico-carotic recess. And this is the left-sided LOCR. This is all an introduction to the skull base because this is the skull base. And this is tuberculum cellae, tuberculum cella, and clivus. The anterior part to this is the planum sphenoidal, which we discuss a bit later. So just brushed up carotids, optics, carotic optic recess, lateral, medial carotic optic recess will be somewhere here. This is the clivus, and this is the cella. Coming to the drainage of the sphenoid sinus. Sphenoid sinus drains into the sphenoethmoidal recess via the sphenoid os on its anterior face. And this is the probe located in the anterior wall of the sphenoid into the sphenoid sinus. Coming to the last sinus, this is the frontal sinus. Frontal sinus is located between the outer and inner table of the frontal bone. The volume is around 5 to 10 ml. It is a pyramidal shaped, whereas the maxillary sinus is a pyramidal shaped with its base medially. This pyramid is a normal pyramid with its apex superiorly and base formed by the floor. Frontal recess. This is the most significant thing which we have to discuss. The anterior border of the frontal recess is formed by the uncinate process and the agar nassae. The posterior border is given by the bulla ethmoidalis. Laterally, it is the lamina papyracea. Medially, it is the middle turbinate and the hiatus semilunaris. Inferiorly, it is formed by the ethmoidal infundibulum, and superiorly, it is the fovea ethmoidalis or supraorbital cell or a anterethmoidal artery. We will discuss in the picture this picture. If this is the frontal recess, anteriorly, it is the agar nassae. Anteriorly, agar nassae. Posteriorly, it is the bulla. Posteriorly, it is the bulla. Laterally, we cannot see in this, but it is the lamina papyracea. Medially, which is the draining part, is the middle turbinate and the hiatus semilunaris. Inferiorly, it is the ethmoidal infundibulum, and superiorly, it is fovea ethmoidalis or supraorbital cell. Superiorly, it is the fovea ethmoidalis. Fovea ethmoidalis is the part of the skull base, which I will show you a bit later. The importance of pneumatization of agar nassae cell. If the agar nassae cell is pneumatized more, it narrows the frontal sinus. In this picture, it is pneumatized, but it is not so pneumatized. But if it is pneumatized to the maximum level, it narrows the frontal recess to the maximum extent like this. Imagine, just remember, the posterior border is suprabullar lamella also. In this, we can see the posterior border is the suprabullar lamella also. Okay. And this is the cadaver dissection picture with the probe placed in the agar nassae. See how big pneumatized it is and how narrow the frontal recess is. In this, we can see the bulla ethmoidalis also. Coming to the drainage of the frontal sinus. This is again an enigma. The frontal sinus is it is said to be of drainage into two directions, which is the medial drainage or a lateral drainage. Medial drainage is occurring when the uncinate. It is based on the attachment of the uncinate. Clinically, we say, but most commonly we see a combination of these attachments, but mainly uncinate is attached into three parts. One, it is lamina papyracea. Two, towards the middle turbinate. Three, towards the skull base. In this, with attached to the lamina papyracea or the skull base, it is a medial drainage. Only when it is attached to the medial turbinate, it should be a lateral drainage. But most commonly or often we see a combination of either of these three. Coming to the Kunz classification. Frontal cells represent the cells of the first ethmoid turbinal. First ethmoid turbinal that pneumatize above the agar nassae towards the frontal sinus. Above the agar nassae towards the frontal sinus. That means above the agar nassae, which is the next anterior part of anterior border of the frontal recess. So according to Kunz classification, if there is a if there is a single frontal ethmoidal cell above the agarnaceae, it is a type 1. If there are one or two tiers of two or three tiers of cells above the agarnaceae, it is a type 2. If there is a cell which is pneumatizing into the floor of the frontal sinus, into the floor, then it is a type 3. And if there is a separate cell inside the frontal sinus, it is a type 4 frontal sinus, frontal cell. Again, the sinuses are divided into 3 groups based on their drainage pathways. According to the 8th volume Scott Brown, they are divided into 3 groups according to their drainage pathways, namely anterior, posterior, and sphenoid compartment. The anterior compartment or the anterior functional unit is comprised of the maxillary, anterior ethmoidal sinus, and frontal sinus. Anterior functional unit comprised of maxillary, anterior ethmoidal, and the frontal sinus, and they drain to the osteometal complex in the middle meatus. The second group is the posterior functional unit, which is comprised of posterior ethmoidal sinus, which drains into the nose through the superior meatus, into the superior meatus. And the last third group is the sphenoidal functional unit, which drains into the sphenoethmoidal recess. Anteriorly, posterior, and sphenoid function unit. For a better understanding, see. This is the frontal sinus, anterior group of the ethmoidal cells, and the middle meatus, and the maxillary. All drain into the middle meatus, into the hiatus semilunaris here. Coming to the posterior cells, they drain into the superior meatus. And this is the sphenoidal functional unit, which drain into the sphenoethmoidal recess. Anteriorly frontal, anterior ethmoidal, and maxillary drain into the middle meatus. The posterior functional unit, which is found by comprised of posterior ethmoidal air cells, drain into the superior meatus, and the sphenoidal sinus drains into the sphenoethmoidal recess. There are 3 groups of the sinuses according to the 8th edition Scott Brown. Coming to the anatomical variations. One important thing to be remembered forever is natural ostium of maxillary sinus can never be seen endoscopically without any surgical intervention. Without any surgical intervention, one can never see the natural ostium. If the uncinate bone is a sickle-shaped bone. The natural ostium is always hiding behind the uncinate bone. If this is the articulation of the uncinate bone, can anyone see the natural ostium? No, because it is hidden behind the uncinate bone. And if ever one can see one can peek into the maxillary sinus, it is only through a two fontanelle, which is an anterior which might be an anterior fontanelle or a posterior fontanelle. These are just mucosal folds without any bone in it, which give a insight into the maxillary sinus. But remember, natural ostium can never be seen without any surgical intervention. They are always hidden behind the uncinate process. This is the anterior fontanelle and this is the posterior fontanelle. If this is the uncinate process, the natural ostium will be located somewhere behind this. The next anatomical variation is a Haller cell. The Haller cell is an infraorbital maxillary cell. It is an infraorbital maxillary cell located inside the maxillary sinus below the orbit. The clinical significance is a Haller cell narrows the maxillary ostium. The next anatomical variation is a Onodi cell. Onodi cell is the lateral posterior extension of the posterior group of ethmoidal air cells. Remember, lateral and posterior. Lateral and posterior location to the ethmoidal air cells is the optic nerve. So, Onodi cell always most commonly pneumatizes onto the optic nerve. It is a lateral and posterior. Remember both of these. Pneumatizes onto the optic nerve. Coming to the anterior skull base. Anterior skull base. Remember these parts are the from the frontal recess till the clivus. If we travel from anterior to posterior, 1, 2, 3, 4, if we start labeling it, If you see your roof and label 1, 2, 3, 4, 5, 6, if that is the skull base, then these are to be the landmarks which you have to find. First thing is always the frontal recess. This is not a part of the, but it is for the understanding. Starting from the frontal recess, the landmarks which one can see are the frontal recess, anterior ethmoid artery, posterior ethmoid artery. That's all. And cella. But there are number of landmarks and number of names which are to be followed beneath these, between these. Frontal recess, anterior ethmoid artery. The place between the frontal recess and the anterior ethmoid artery is the anterior fovea. Anterior to the anterior ethmoid artery is anterior fovea. The place between anterior ethmoid artery and the posterior ethmoid arteries is the posterior fovea. Posterior fovea. See, easy to remember is anterior to anterior ethmoid artery is anterior fovea. Anterior to posterior ethmoid artery is posterior fovea. Remember like that. And once you cross the posterior ethmoid artery, most commonly or most often the landmark which you see is the face of the anterior face of the sphenoid, and there the planum sphenoidal starts. Planum sphenoidal, once it goes into the sphenoid sinus, it slopes downwards and it lands onto the cella. But before the cella, there is a tuberculum cellae, followed by cella, and followed it below it is the fossa, which is the clivus. So once we will revise it: frontal recess, anterior fovea, anterior ethmoid artery, posterior fovea, posterior ethmoid artery, planum sphenoidal, tuberculum cellae, cella, clivus. Okay. We'll have a video demonstration of the same later, but see, this part is the anterior frontal recess. This is the anterior ethmoid artery. This is the posterior ethmoid artery. So frontal recess, anterior to the anterior ethmoid artery is the anterior fovea. Posterior to anterior ethmoid artery and anterior to posterior ethmoid artery is the posterior fovea. Posterior to the posterior ethmoid artery is the, see, this is the sphenoid sinus, and this is the anterior face of the sphenoid. There is not much gap between these two, and this is the starting of the planum sphenoidal. And now that we cannot see beneath this planum sphenoidal is continues till here. And once we see the cella, the area between the planum and the cella is the tuberculum cella, and somewhere below it is the clivus. Coming to the two fossa, Pterygopalatine fossa. Before actually jumping into this discussion, I will just want to request everyone to imagine two walls, one anterior and one posterior. The anterior wall is continuous, whereas the posterior wall is broken into 1, 2, 3 parts. Okay, this anterior part is the posterior wall of maxilla, and this posterior part is the, when it is broken, the medial most is the pterygoid plate, and beside it are the greater wing of sphenoid. Okay, coming to Pterygopalatine fossa, it is a major distributing center for branches of the maxillary nerve and the pterygopalatine part of the maxillary artery. The contents being maxillary nerve, parasympathetic pterygopalatine ganglion, the third part of maxillary artery, accompanying veins, and the surrounding fatty matrix. Coming to the boundaries. We'll just read out and then we'll go and see. The anterior boundary is the posterior wall of the maxilla, posterior surface of the maxilla. Posteriorly, it is the base of the lateral pterygoid plate and the opening of the foramen rotundum and the pterygoid canal. Inferiorly, it is the junction of the palatine bone and maxilla. Remember the first picture when we have seen the perpendicular to the maxilla, palatine bone articulated in the maxilla. That is the inferior border. Superiorly, it is the greater wing of the sphenoid and the inferior orbital fissure. Medially, it is the perpendicular plate of the palatine bone and the sphenopalatine foramen. Laterally, it is the pterygomaxillary fissure. See, remember one easy, very easy thing. This is the nasal cavity. This is the pterygopalatine fossa. The communication is the sphenopalatine foramen. Nasal cavity, sphenopalatine foramen, pterygopalatine fossa. Nasal cavity, sphenopalatine foramen, pterygopalatine fossa. Pterygopalatine fossa, pterygomaxillary fissure, infratemporal fossa. Nasal cavity, sphenopalatine foramen, Pterygopalatine fossa, pterygomaxillary fissure, infratemporal fossa. This is a chain communication in the similar manner. See, the medial communication is the sphenopalatine foramen to the nasal cavity. Laterally, the pterygomaxillary fissure. Now we will see in various pictures. This is the maxilla, posterior wall of the maxilla. This is the pterygopalatine fossa. This is the posterior wall of the maxilla anteriorly, and this is the perpendicular pterygoid plate posteriorly. These are the pterygopalatine fossa in this picture. I have collected some 2 to 3 pictures so that we can have a better understanding. In this, see, this is the superior border, greater wing of sphenoid, lateral pterygoid plate posteriorly, anteriorly it is the maxilla, and this is the pterygopalatine fossa. See, in this, the nasal cavity communicating with the pterygopalatine fossa via the sphenopalatine foramen. This pterygopalatine fossa communicating with the infratemporal fossa via the pterygomaxillary fissure. This is what we have just read earlier. Nasal cavity, sphenopalatine foramen, pterygopalatine fossa, pterygomaxillary fissure, and infratemporal fossa. In this picture also, we can clearly see this is the posterior wall of the maxilla, and this is the perpendicular plate of the pterygoid plate, lateral pterygoid plate, and superiorly this is the greater wing of the sphenoid, and this is the pterygopalatine fossa. And if you can see clearly, this is pterygomaxillary fissure and pterygopalatine fossa, and this open space is infratemporal fossa. Pterygopalatine fossa, pterygomaxillary fissure, and infratemporal fossa. Communications of the pterygopalatine fossa. Instead of reading this whole thing, we'll just see this table, which is giving the whole information in a single table. This is the boundary structure, boundary structure forming it, communicating with, communicating via, and transmission. What is the anterior wall? It is the posterior wall of the maxilla. Anterior communication is towards the orbit via the infraorbital fissure. The anterior wall formed by the posterior wall of the maxilla is communicating into orbit via the inferior orbital fissure, transmitting infraorbital vessels and nerves ascending branch of the pterygopalatine ganglion. The posterior wall is formed by the lateral medial pterygoid plates, the pterygoid process, communicating with the middle cranial fossa via the pterygoid canal, transmitting the transvidian nerve and vessels, transmitting vidian nerve and vessels. The medial wall is formed by the perpendicular plate of the palatine bone, which is communicating towards the nasal cavity with the nasal cavity via the sphenopalatine foramen, sphenopalatine artery and branches, pterygopalatine ganglion branches to the nasopharyngeal mucosa. Lateral wall is formed by the gap between the pterygoid plates and the maxilla, which is the pterygomaxillary fissure. The communication is with the infratemporal fossa, and the communication is via the pterygomaxillary fissure, transmitting the maxillary artery. The superior wall is formed by the greater wing of sphenoid, and it is communicating to the middle cranial fossa via the foramen rotundum. Foramen rotundum, we all know, transmits the maxillary nerve. Inferiorly, there is no wall present, and it is communicating with the oral cavity roof via the greater palatine and lesser palatine canals, transmitting the greater palatine and lesser palatine nerves and vessels. Coming to the infratemporal fossa. Remember, anteriorly it is the posterior wall of maxilla, and if there is a posterior wall of maxilla, behind it, it is the pterygopalatine fossa and infratemporal fossa communicating via the pterygomaxillary fissure. Infratemporal fossa is irregularly shaped space deep and inferior to the zygomatic arch, deep and inferior to the zygomatic arch, deep to the ramus of the mandible and posterior to the maxilla. See, there are 3 structures: zygomatic arch, deep to the ramus of the mandible, zygomatic arch, deep to the ramus of the mandible, and posterior to the maxilla. It is a irregularly shaped space. It communicates with the temporal fossa through the interval between the zygomatic arch and the cranial bones. The temporal fossa is what is superior to the zygomatic arch, whereas the infratemporal fossa is inferior to the zygomatic arch. As simple as that. Superiorly it is the temporal fossa, and inferiorly it is the infratemporal fossa. The main differentiating is the zygomatic arch. Now we'll see some diagrams in order to understand. Okay, coming to the boundaries. Anteriorly, it is the same boundary, posterior surface of the body of the maxilla. Roof, it is again formed by the greater wing of the sphenoid, infratemporal surface of the greater wing of sphenoid, which has been the superior roof of the Pterygopalatine fossa also. The medial boundary is lateral pterygoid plate and pyramidal process of the palatine bone. The lateral part is the coronoid process and the ramus of the mandible. Inferiorly, there is no, and it is continuous with the neck. Posteriorly, it is with the temporomandibular joint and the styloid process. See, in this picture, this is the posterior of the maxilla and this is the lateral pterygoid plate. The inside thing is the pterygopalatine fossa. This is the pterygomaxillary fissure and it is communicating to the infratemporal fossa. In this picture also, this is the posterior wall of the maxilla. This is the pterygomaxillary fissure. These are the pterygoid plates. This is the pterygopalatine fossa, pterygomaxillary fissure, and communicating this open space. This open space is the infratemporal fossa. Below the, this is the arch of the zygoma, zygomatic arch. Below it is the infratemporal fossa. Posterior of the maxilla, perpendicular to the perpendicular pterygoid plate, sorry, and arch of the zygoma. This is the infratemporal fossa. In this also we can clearly see this is the maxilla posterior, pterygoid plates, and this is the open space below the zygomatic arch, which is the infratemporal fossa. And this greater wing of sphenoid, we can see the three foramen: foramen lacerum, foramen ovale, and foramen spinosum. Contents of the infratemporal fossa. Contents of the infratemporal fossa are mandibular nerve, maxillary artery, pterygoid plexus of vein and medial and lateral pterygoid muscles, lower part of the temporalis muscle, chorda tympani nerve, and the otic ganglia. Communications. Communications are with the temporal fossa through a gap deep to the zygomatic arch, with the cranial cavity into the middle cranial fossa via the three foramen: foramen ovale, spinosum, and lacerum, with orbit via the inferior orbital fissure, with pterygopalatine fossa through the pterygomaxillary fissure. Okay, this is the end of the presentation. But even after seeing so much, listening so much theory, without seeing a cadaver dissection video, it will be more or less of a confusion and a lack of understanding. So I couldn't find a better video than a video of my mentor, Dr. Janakram sir. I'm just playing, and Harsha.
Sir, yes, sir.
Okay, just let me know whether the audio of this video is audible or not, or else I'll talk along with. Okay.
Yeah.
I am Dr. Janakram.
Is it audible?
Royal Pearl Hospital and ENT endoscope takes off in the anterior end of the from Royal Pearl Hospital section along with my
Is it audible, Harsha?
with the diagnostic nasal
Yes.
endoscopy.
Harsha,
Yes, it is audible, sir.
is it clear?
Yeah.
Okay.
Using a 0-degree telescope, and this is the aircraft technique. The landmarks being the inferior turbinate, the middle turbinate, and the superior turbinate. The sphenoid os can be seen in your picture. That's the axillary ostium which can be seen there.
Okay, what I'll do is I'll just mute the voice and I'll tell, because we have discussed some points. We have to discuss some points along with it. And see, this is fontanel. This is the fontanel which is seen in this video. And this is the inferior turbinate, middle turbinate, superior turbinate, and this is the uncinate process, behind which we can see the fontanel here. See, this is behind the uncinate, and this is the posterior fontanel. This is the middle turbinate, inferior turbinate, septum, and if we see, this is the septal body also seen in this. Coming to the nasopharynx, going to the nasopharynx, this is the nasopharynx, fossa of Rosenmuller. Landmarks, this is the eustachian tube, torus tubarius, fossa of Rosenmuller, and area of the adenoids. And medial to the middle turbinate, this is the axilla of the middle turbinate. This is the uncinate process, and this is the bulla ethmoidalis. This is the uncinate bulla ethmoidalis, and this is the middle turbinate. See, we can if we remember, the first part of the middle turbinate is in the sagittal plane. The first part of the middle turbinate is in the sagittal plane, and gradually it turns and attaches to the. This is the first part. The second part will be seen once the dissection is started, and the posterior part is seen somewhere. This is the anterior part, middle part, and this is the posterior part where it is attached to the lateral wall. First, we will start with an MMA. Okay. Okay. This is the vertical part and horizontal part. We insert a backbiting forceps at the junction of the vertical and horizontal part, and then we take 1, 2, 3 bites so that we can feel the anterior hard bone, and this is the horizontal part of the uncinate bone. We have to remove the horizontal part of the uncinate bone, and then we can go inside the maxillary sinus. Sir is doing an uncinate flap in this, so we'll skip that part and see. This is the inside of the maxillary sinus. And even in the inside, if this is the 70-degree scope which is put to see the interior of the maxillary sinus, this is the roof of the maxillary sinus. Remember, we have already discussed the roof of the maxillary sinus. The infraorbital bundle of vessels, infraorbital bundle traverses along the roof, and this is the infraorbital nerve on the roof of the maxillary sinus. And this is the infraorbital nerve on the roof of the maxillary sinus. And continuously, this is the vertical part. We have already removed the horizontal part, and this is the dissection of the vertical part of the uncinate. Once that vertical part of the uncinate is dissected, remember, we have already discussed the uncinate attaches to the roof, and it decides regarding the drainage of the frontal sinus. This is a 70-degree view, and this is the attachment of the uncinate, and this is the agar nasal cell. Remember, the bigger the agar nasal, the posterior the frontal recess will be. In this video also, this agar nasal has pushed the drainage of the frontal sinus posteriorly. This is the attachment of the uncinate. Uncinate attached to the skull base, there is the medial drainage. Okay, so the dissection, the drainage is posteriorly, so the ball probe is kept posterior to the agar nasal, and this is the uncapping of the egg, and that's how we have seen the frontal sinus. This is the frontal recess, and that is the frontal sinus posterior table, which can be seen in this video. This is the 70-degree telescope which has been used. And proceeding to the anterior ethmoidals. This is the bulla ethmoidalis, and one should always enter inferior and medial in order to enter the anterior ethmoids. And this is the entrance into the anterior ethmoidal artery, anterior ethmoids, by puncturing the bulla. See, this is the middle turbinate, and gradually you can see this middle turbinate and transforming its axis orientation. Vertical orientation is slightly going to the coronal plane, and once it is completely coronal, it will completely become axial and attached to the lateral wall. So these are the small cells in the anterior ethmoidal air cell, anterior ethmoids, which are being removed. Fine dissection in order to preserve the ground lamella and to show the ground lamella intact. Yeah. So one can clearly see this is the ground lamella, and this is the anterior ethmoidal artery. This is the frontal sinus, frontal recess, and this is the anterior ethmoidal artery. If this is the frontal sinus and this is the anterior ethmoidal artery, this part is the anterior fovea. Most of the times we increase the size of the frontal recess, we expand this frontal sinusotomy by at the expense of the anterior fovea. This is the anterior ethmoidal artery, and this is the middle turbinate, which is slowly, gradually changing its axis and becoming the basal lamella. Now we are entering the posterior ethmoids. Remember this, once we puncture the basal lamella or the ground lamella, the posterior ethmoids are entered. And if we can note it, the posterior ethmoids are larger in size and lesser in number, whereas there were numerous anterior ethmoid layer cells. This is a cadaver dissection, so the mucosa is being stripped off, where in live cases the mucosa is very, very important and should be handled very carefully. And posterior ethmoids are entered, and now we'll jump to the part where the posterior ethmoidal artery. These are all the posterior ethmoidal layer cells which are being removed. And now we are trying to enter into the sphenoids. We are trying to find out the normal process the approach we follow is the intermediate approach. There are three types of approaches to enter the sphenoid os. One is medial, the second one is intermediate, and the third one is a lateral. Medial is medial to the middle turbinate, lateral is lateral to the middle turbinate. Our approach is the intermediate approach. We go through the middle turbinate, find the superior turbinate, and then find the sphenoid os. This is the way we regularly do the sphenoid sinusotomy. So this is place where the middle turbinate is ending and the puncturing the ground lamella. This is the superior turbinate which we have found. And once we dissect the superior turbinate, we'll remove the lower third of the superior turbinate, and then we find the sphenoid os. This is how we remove the inferior third of the superior turbinate and proceed towards the sphenoid os. Yeah, we have already had a small glimpse of the sphenoid os on the anterior face of the sphenoid, and now as we proceed posteriorly, we can have a clear picture of the same. Yeah, okay. Once that is seen, it is a matter of time to widen it. And further widening it. This is the right-sided sphenoid sinus. So we will see the right optic nerve, right carotid artery, right carotid optic recess if the pneumatization is more, and then this is the optic nerve, this is the carotid, and this is the clivus in the right sphenoid sinus. And that's the end of this presentation. 1 minute. One thing which I have forgotten is the lateral sinus, lateral recess of the sphenoid sinus. I will just check whether I have a picture of that. There is another anatomical variation. Normally, 1 minute. Yeah. Now this will anyway be discussed by Dr. Venkatram Reddy sir tomorrow. But I just want to tell from my side. This is the CT scan of a sphenoid sinus. Remember how many landmarks we can see. These are the pterygoid plates. This is the right side sphenoid sinus. This is the left side sphenoid sinus. These are the optic nerves in the optic canals. And this normally, this part of the pneumatization is generally not seen. If there is a big pneumatization, only then we can see such thing. Or else this part is generally the body of the pterygoid. Remember what we have learned is this is the body of the sphenoid, attachment below to the pterygoid process. Pterygoid process again gives two pterygoid plates, medial and lateral pterygoid plates, and the pterygoid body itself is pneumatized very much. That's why this lateral recess has occurred. This is another anatomical variation which I've just forgotten to mention. Harsha, over to you. Harsha? Harsha, are you here?
Sir, yes, sir.
Yeah, over to you, man. Thank you.
Sir, thank you, sir. There are not many questions. We'll conclude for the day.
Oh, we'll call it a day.
Yes.
Okay. Thank you very much. Thank you, everyone, for giving me the opportunity and giving me a chance to share my knowledge to you. Thank you, Harsha. One person has just asked about Nick's triangle.
Yes.
Nick's triangle, I think Sir has shown in this. I thought I'll just keep off. I'll just tell you 1 minute. Just give me a minute. I'll just show them the Nick's triangle also. Once the inferior turbinate is lateralized, where is the Nick's triangle? Sir demonstrated it. Okay, I'll just post my mail ID and I'll tell that answer to him. Just note down. Whoever has asked, I'm sorry I could not find it immediately. I'll just send you. Just drop a mail on my mail ID. I'll just discuss with you what Nick's triangle is. I think Harsha that will suffice.
Okay, sir.
Yeah, Harsha,
Yeah.
thank you. Thank you very
Thank you, sir. Once again, it was a very great and extensive lecture. I hope all the postgraduates who have attended have really benefited from today's class. Tomorrow we'll be moving on with radiology of PNS, and hopefully we'll all see you at the same time. Thank you, one and all. Good night.
Yeah, one personal request from my side, Harsha.
Yes.
One personal request to all who have participated today. Please don't forget to join the radiology class tomorrow because that will reinforce whatever you have seen today. Even be it the frontal sinus cells classification, be it the ethmoidal air cells, be it the supraorbital elementalization, be it the anterior ethmoidal, everything, whatever we have discussed today will be reflected in the same way tomorrow. If you follow tomorrow's class, it will be a great feast for you because you can remember everything and reinforce it. Okay. Thank you. Thank you very much, Harsha.
Thank you,
Let's
sir.
conclude.